Hello, friends. So I'll be talking on this journal review in 2021. What are the key landmark articles that had come? So this talk I had to give in one of the Calcutta meet. So I'll take you through system wise. So the topics that I was meant to cover was perioperative articles, transfusion related articles, oncology related articles, and the endocrine related articles. So the key articles that is of relevance to intensive care that have come out in 2021. So in this lecture, I'll just take you through perioperative, one of the key articles that came. So when we look at the background of perioperative transfusion practices, so I'm sure many of the intensivists who are hearing to this may have heard of this TRIC-3 trial. So this TRIC-3 trial came in patients who underwent cardiovascular surgery, predominantly CABG, who were at a moderately high risk for death. Here in TRICS-3, they compared between restrictive versus liberal transfusion group, and it was found that the restrictive group was non-inferior compared to the liberal group in this particular study. And the restrictive transfusion threshold was 8 grams percentage in this particular trial. And here they even looked at the 838 ICU patients. So the patients who underwent surgery who were in ICU for more than 24 hours stay. And they found there was no mortality difference as well between the restrictive group and the liberal group. So which means to say restrictive group maintaining hemoglobin at 8 and above is good enough, and we don't need to maintain targets of more than 8 or 10 for that matter. So that was the conclusion of this TRICS-3 trial. Just to give a background as a pretext for the trial that was done in 2021. Then there was this TRIS trial. So this TRIS trial came from the Scandinavian countries, so which are predominantly the Norway, Finland, and Sweden. So this study was done in septic shock, where they looked at the transfusion threshold, where they compared liberal versus restrictive, and 7 grams was the hemoglobin threshold, and they found 90-day mortality. There was no difference between the liberal group and the restrictive group. So based on this trial, even now, if the practices that we have is we accept a hemoglobin threshold of 7 in intensive care based on this particular trial, because it was shown that it is non-inferior and there was no difference in any of the outcome variables. So, and this was an interesting study which came in 2013 in patients with upper GI bleed. This was a Spanish study. Even in upper GI bleed, they showed restrictive transfusion, in fact, was associated with lower mortality. Here also the transfusion thresholds was kept at 8. So as you see, even in a high-risk patients, like cardiovascular patients, 8 was found to be good enough. In septic shock, in ICU patients, 7 was good enough. Even in patients with upper GI bleed, restrictive transfusion led to better outcomes. So this is the background of the study that we are going to deliberate upon now. So this was a study which came in 2021 called the Reality Randomized Clinical Trial. It came in JAMA. So the title of the trial was Effect of Restrictive versus Liberal Blood Transfusion Strategy on Major Cardiovascular Events among patients with acute myocardial infarction. I think this area, why it is important is, I'm sure many of the listeners would agree, some of the cardiologists would still say that we need to maintain higher hemoglobin to optimize your myocardial oxygen demand and myocardial oxygen consumption and the coronary blood flow and so on and so forth. So this was a French trial, basically to answer that question whether restrictive is good enough even in patients with acute MS. So here again the comparison was to compare between the restrictive versus liberal and to ascertain whether restrictive transfusion is non-inferior to the liberal transfusion. That was the hypothesis. And the triggers they maintained was 8 grams. So one group had, they maintained hemoglobin less than 8 grams per cent. And the other group, they maintained hemoglobin less than 10 grams, which means 8 to 10 is what they maintained. So this is in patients who had myocardial infarction. So there were 342 patients in the restrictive group where hemoglobin, when we say trigger, they transfuse blood if hemoglobin came to less than 8. And here in less than 10, they transfuse blood when the hemoglobin came down less than 10 in myocardial infarction. They had 324 patients in that group. And these patients were followed up for 30 days. So it was an open label, non-inferior randomized controlled trial. So this trial was done in 35 hospitals in France and in Spain. So predominantly a French trial, and there were centers in Spain as well. Study was done between March 2016 to September 2019. So it was done over 3 years. And they had 668 patients enrolled in patients who had a myocardial infarctions with hemoglobin lying between 7 to 10 grams per cent. So this was the inclusion criteria. 70% of these patients had non-STEMI and 30% of the patients had STEMI in this group. So they took all the acute MI patients and they randomized between these two hemoglobin thresholds to see if there was any difference in the outcome. So the primary outcome was to look at major adverse cardiac events, which was composite of all-cause death or someone who develops a stroke after MI or someone who has a recurrent MI and someone who has to undergo emergency PCI. So the composite outcome, because in all cardiovascular studies, the outcome typically they look at is major adverse cardiac events, which is a composite of all these because these are all related to the MI. So someone who has a death or a stroke or a recurrent MI or undergoing emergency revascularization. And they defined non-inferior as relative risk of upper confidence interval less than 1.25. So you have confidence interval range. So they looked at upper limit less than 1.25 as being significant for being non-inferior. So that was a criteria they had. Secondary outcome was to look at individual components of primary outcome, which means they looked at all-cause death separately, they looked at stroke separately, recurrent MI. So they looked at that separately as a secondary outcome. So in the results, the median age of the patients was 77, which means they were fairly elderly. So this is the range 69 to 84. 42.2% of the patients were females. And this was the day 30 major adverse, 668, 342 in the restrictive group, 324 in the liberal group. As you see, day 30 major adverse cardiac events was 11% as compared to 14%. And you see relative risk, it is not statistically significant. But what they show is the primary outcome was to look at non-inferior. So non-inferior, you see 1.19, which is less than 1.25, which means it fulfilled the criteria that this study was good enough to say that restrictive transfusion was non-inferior to liberal transfusion. And they looked at all-cause death. As I said, they looked at the individual components of the composite outcome. So this was the composite outcome. They found that restrictive was non-inferior to liberal. And when they looked at the individual components, all-cause death, there was no difference, 5.6 to 7.7%. Recurrent MI, 2.1% in restrictive, 3.1% in liberal. And patients needing emergency revascularization, there was no difference between restrictive and liberal, 1.5%, 1.9. And stroke also, there was no. So these are the individual components of the composite outcome of major adverse cardiac events. There was no difference between any of these. And the number of patients needing more than 1 unit of transfusion, as you see, was definitely more in liberal because they had to get more to maintain hemoglobin when the hemoglobin is less than 10 as compared to the restrictive, which got 35.7%. And what about the harm? So they looked at evidence of harm and they found acute lung injury was more common in the liberal. So this is a big worry for our intensive care, where we have always said that giving more transfusion leads to more TRALI and more acute lung injury or respiratory failure or patients needing oxygen. And that was found to be pertinent even in this study. 2.2% of the patients in the liberal group had more acute lung injury as compared to 0.3% in restrictive. And the infections, as you see, we also understand that giving unnecessary transfusion comes with its own set of problems, and infection is one of them. And here they found 5 patients had secondary infections, 1.5% as compared to 0 in restrictive group. So the key strengths of this study is it's a very important study, especially in this particular cohort of patients with MI, where there is paucity of evidence. And this study possibly is conclusive to say restrictive is as good as not transfusing unnecessarily. And this had a good sort of a bearing on the clinical outcome, because this particular study's strength is they looked at all the relevant pertinent clinical variables that any clinician would be interested, or even a cardiologist would be interested, because cardiologist would be more worried about death, recurrent MI, and emergency revascularization. And all these, it showed that there was no difference and it was non-inferior. So we can accept a hemoglobin of 8 and no need to transfuse unnecessarily to targets of 10. So that is what this study shows. And the follow-up of all the patients were nearly complete, and that was the another core strength of this study. So to end this, conclusions is in patients with acute MI, restrictive versus liberal. So restrictive transfusion was non-inferior for all the 30-day major adverse cardiac events as a composite outcome. Even individual events like stroke, death, recurrent MI, and revascularization also, restrictive transfusion was non-inferior. So possibly most intensivists would be following this. Maybe this is a study which would again sort of gain conviction of our cardiology colleagues also, that we can accept hemoglobin of 8 and no need to transfuse unnecessarily to target hemoglobins of 10. So that would be the summary of this study, and possibly this would help in unnecessary transfusions, which may lead to acute lung injury and secondary infections, which is the bane in our intensive. So thank you, friends. So I'll stop here.